welcome to the Research Works podcast, live from the European Academy of Childhood Disability Conference 2024 in Bruges, Belgium. Join us for interviews with keynote speakers, world-renowned researchers and clinicians, and behind-the-scenes stories from one of the great paediatric conferences in the world.
And now we have Dr Sarah Reedman from Cerebral Palsy Alliance and University of Queensland. Hello, Sarah.
Hello, Dana. It's so nice to be with you again.
Same. I love that we're always, like, when we're in the same space, we have so much to talk about.
Yeah.
And I feel like I've just been texting you the last few days going, where are you? Where can I connect with you?
How can we meet?
Yeah, that's right. Finally made this work, made it happen. Like, you're presenting a few times over this conference, aren't you?
Yeah, I've got, I'm involved in a poster, and then I've also got a mini symposium this afternoon.
Oh, wow. That's absolutely amazing. And what's the topic of the mini symposium?
It's about optimizing participation in physical activities and sports. Yeah.
Wow. Of course.
Yes.
I mean, that's brilliant. And I love that work has been continually evolving, and that we're working together on that. In fact, we're working on some projects together that really try to maximize that. So it's wonderful to have friends in the industry doing this together. But I thought today, as a topic that we can talk about, is something that's so relevant in clinical practice. I think you and I have both been seeing things on social media, or people reach out to us to ask us questions about it, because the last time we spoke about it, it did stir up a lot of conversation, which is great. Like, having conversations and opening dialogue is great. And that theme is crying or distress during therapy, and what's normal, what's not, what's acceptable, what's not.
Yeah.
Yeah.
Yeah. Dan, I'm so glad that you want to talk about this, because it's something that I think about all the time, and we really need to have an open conversation about it.
Yeah, yeah. I think the thing that I see in therapy, and even when families bring their child to see me and my team, and we describe to them, look, we don't want to see crying, and sometimes kids do cry in their sessions, and when they do, it's not that they're not going to cry in my sessions. It means I need to stop, and we need to figure out the why. And my thought process behind that is it's just not worth pushing forward if we're going to damage any relationship along the way, because that can have a lifelong impact.
Yep, absolutely.
Yeah. Yep. What are your thoughts? What are some of the things that you've been seeing since the last time we spoke?
Yeah. Absolutely. I think what I've seen is a lot of probably well-intentioned comments, from clinicians and also from families as well, because that's, the information that they have available to them. Yeah. Well-intentioned comments about crying or distress in therapy is a normal experience. It's something that we should expect to happen because therapy is hard. And I get it. Like, I understand. Yeah. Because that's part of that is true. There's a kernel of truth there. Yeah. Therapy can be very challenging, very physically challenging, emotionally challenging for young people of any age. But that doesn't mean that we have to accept that. And also we should be talking about why distress in therapy is actually going against what we would like to achieve, particularly over a long term. Yes. We have to think about not only in the immediate therapy session, getting something done. Yeah. Well, actually, what's the trade-off over the child's whole life and the long-term situation? The long-term gains.
Yeah. Look, that reminds me of a story that I've recently come across, where a family were going to come to see us, but then they felt their child was feeling quite traumatized, because every time they'd gone to see a therapy provider, and the child was just upset the whole time, crying throughout the whole time. And the parents are like, well, I don't know what to do anymore. Maybe we should just stop doing this altogether, because every time now my child goes into a room, every time they see a plinth or a bed, they completely freak out and they start crying. Yeah. And they're like, well, what do? We need to do therapy, but they're really upset. So do we stop? Yeah. What do you think of when that sort of scenario comes about? Because that's not a unique scenario. I mean, we've heard this before.
No, I agree. I've heard it before. I've seen it before. And I guess what I think is that's really sad. Yeah. That, to me, when that's happened, and if you think about, generally speaking, child neurodevelopment, we have most therapists have done a 6 months or semester of psychology in their undergraduate training. Like, it's part of your mandatory, undergraduate training. Right. Yep. You get to learn about child neurodevelopment. You get to learn about attachment theory. Yes. You get to learn about how infants and children form relationships.
Yeah.
And what we know is that infants and children need people that show love, care, and attention towards them. They need people that are attentive to their needs.
Yes.
So when a child expresses that they need something,
Yes.
that, they're frightened, that they're scared, that something is terribly distressing or traumatizing to them, they need someone to show attention to that and respond to that sensitively.
Yeah.
And so when children are crying in a therapy session and showing that they're distressed, there could be an element of that that's related to the child's neurodevelopmental disability. It could be that that they've had a sensory experience that for a typically developing person, very innocuous, not a problem.
Yeah.
But what we're telling that child, if we push through their distress and we don't respond to it, we don't stop the session, and we don't find a way to help bring that child back into a normal nervous system level of regulation. We're telling that child that we don't care about their distress. We don't care about it.
We're not acknowledging it.
We're not acknowledging it. We don't think it's valid. And that child eventually learns that people won't listen to them, that people won't listen to their signals of distress. And we know that creates trauma. That's it's not a secret.
That's right. Well, and the response from there could be two things, perhaps. It could be it escalates the next time, because if you're not going to listen to me right now, I am going to make sure I can be as loud as I possibly can. But then if that's still not listened to, maybe the other reaction is I'll just be silent.
That's right.
And you silence a voice, which both scenarios break my heart.
Yeah, absolutely. Yeah, absolutely. And then that young person integrates that experience into the rest of their life.
Oh.
If you think about a person, a child with cerebral palsy, for example, they become an adult with cerebral palsy. They're going to live with cerebral palsy for their entire life.
Yeah.
And the reality of that means that they'll need medical interventions, surgical interventions, therapy interventions.
It doesn't stop.
For the rest of their life, to help maintain participation, quality of life, all of the amazing things that are important.
Yeah.
And if you have early life experiences of trauma related to healthcare intervention, think about the long-term impact that that's going to have on that person and how it could really significantly impair their ability to seek care that they need throughout the rest of their life.
Yes.
And also consent, like give informed consent to the care that they need and it is in their best interest for the rest of their life.
Yes.
That's what I think about. And that's why I'm really glad that we're having this conversation.
Yeah, and that's such a great point. Consent is vital. And for a young child, when you go into research studies, people think of consent if they're old enough, not old enough, who consents for them. And for children, I think a really almost easy way of seeing whether you've got consent is whether the child wants to participate or not.
Yeah, that's right.
Right? If they're not really wanting to, then you've got to go, okay, all right, not push, let's work out why.
Yeah.
And you, like you said before, sometimes therapy can be hard because we do want to push, for sure. We do want to push. Of course, we want to push that boundary. We want to challenge, but the increments in our mind might be very different to the increments for the child. So maybe we've got to step it back a little bit, take a step back. Maybe it's too much sensory. Maybe it's too much feedback. Maybe it's too much handling. Like they're all increments, aren't they?
Yeah, absolutely. Or just something else happened that day, for that young person. And
didn't sleep, didn't eat.
That's right. Yeah, exactly.
That's right.
Absolutely. Yeah. And, it's about, I think about it like relationships. So as a clinician, especially working with children and young people who have a disability, and that means that, you might be their clinician for a really long time.
Yeah.
Years.
Yeah.
Could be having a relationship with that person for years. The cornerstone of the efficacy of your treatment is the therapeutic relationship. Yeah. And we know that. And, our colleagues in occupational therapy have been trying to tell us that, and psychology have been done so much research and been trying to tell
that. It ain't new, right?
This is not a new concept. The cornerstone of your efficacy as a clinician is your relationship with the child and with the family. And so if you're going to establish a long-term relationship with a little one, with a child, with an adolescent, the first thing that you should think about is, not how hard I can push that person. That comes that comes later. That's important.
Yeah.
But how can I build the most effective, loving, kind, therapeutic relationship with this child?
Yes.
And that means ultimately being sensitive to their distress, caring about them, as a human being, respect, empathy, and there's a back and forth. Relationships are not one way, right?
That's right.
The relationship is about is a back and forth. It's a reciprocal relationship, and there are so many ways we can demonstrate that with young people, and that's step one.
Absolutely. And look, there's so much to unpack still, because I even think about the fact that yes, there is our relationship, and it's so important because there's a trust there. The other part is we also want to protect that relationship with their parents as well, because I think often parents are, they're with their child during these sessions, and if the child is crying and the therapist continues to push, and almost, the parents might be thinking, oh, this is the way forward, like this is what we need to do. The child knows their parent is there, but they're not coming in to comfort them. And I think that plays on not just the parent, but also on the child. I mean, what do you think about that?
That's true. Absolutely. The parent is the child's sort of foundational attachment, and a child would expect that their parent is also sensitive. Or expect that their parent is the most sensitive to their needs.
Read their cues.
Absolutely, read their cues. So if clinicians are hopefully not, but if clinicians are encouraging parents, not to respond to the signs of their child's distress, you've got to think about the potential long-term impacts of that. I think it's really important for us to be sensitive to a child's primary attachment, which is often with their caregivers.
Yeah, absolutely. I've seen comments along before about, I think it was in response to our last conversation actually, and there was a comment that was made about, well, children go to school and they cry, so why is this any different? I mean, I think that's worth unpacking a little bit.
I mean, look, the first thing, you've got to laugh, don't you? Because the first thing I think about that is, do we want children to cry at school? Like that's the first
I'm pretty
question.
sure the teacher's like, come on.
Right. Like that is possibly, you just go back to what we know about learning. And actually a lot of what we know about learning and neuroplasticity, the way that our brains absorb information, comes from educational research.
It does.
It comes from school, educational research. Yep. And oodles of that, decades of that, tells us that children learn best when they are not crying. In fact, when they're not crying.
When they're not distressed, yes. That's right.
Exactly. So that is the first thought that I have in response to that.
And look, I thought the same too. And I thought, well, we know about cortisol, and I've done talks before about the effect of cortisol on learning and how it actually disrupts neuroplasticity. And I thought very quickly about, the time when you're studying for an exam, and there was once where I realized there was too many exams to study for, and I was super stressed and I was cramming for my next exam. But because I was so stressed, I couldn't learn a single thing. Yeah. I looked at my paper and went, everything is just jumbled up. I'm not learning. And I thought, that's what it's like when our kids are distressed. Yeah. It's the same thing. We've established that learning is learning. Doesn't matter who you are, what condition you have, there's principles of learning, but you can't actually learn anything when you're stressed.
Yeah, that's right.
Really foundational. Yeah. I thought that was worth covering because that was an interesting comment in reply to what we were saying. So I thought that was a really good one. All right. What do you think about when we tend to see a lot of distress, I suppose we see that a lot online, social media, and there's been a lot of comments that I think we've been seeing and noting together about it as well. And my sense is that there is this desire to push through because early intervention, the first 1,000 days, we have to get in there because we need to make an impact now. What do you have to say about that?
Yeah, I mean, it's like, again, it's one of those things that comes from kind of a well-founded or logical place in terms of we know that age is related to neuroplasticity. So the younger you are, the more more neuroplasticity you have. Yeah. But what I say to that is our brain is neuroplastic throughout our entire lifespan. Yeah. We have capacity for neurodevelopment, change, reorganization, plasticity, learning every single day of our lives. Yeah. And if you are pushing through distress, thinking that that is more important, then you have to realize that you might actually be kind of robbing Peter to pay Paul, because that's probably, you know what I mean? That's kind of the analogy. You think you're actually kind of causing harm now to really not do very much not do very much later. You know what I mean?
Yeah.
If you create a foundation of a respectful, trusting relationship and you make that your priority, then ultimately you're going to be able to push that child further than you could have pushed them through the distress.
Yes.
Because with a trusting, respectful relationship, you can go to the moon. You can achieve anything,
and that's exciting,
and that's so exciting, right? Like, don't you want to go to the moon? Like, don't you want to create a relationship with a young person that means that, you know, the sky isn't the limit? I don't think there's a clinician in the world that wouldn't want that, and that does mean, I mean, unfortunately, it might take you a little bit longer to get there. But that's okay, and it also means that you're going to know that child better.
Yeah.
You're going to know
what they love,
and your clinical reasoning will be better because you deeply understand what that little person needs, what they want, what their motivations are, what interests them. And I guarantee that you'll achieve better outcomes.
Absolutely. And as a clinician, your fulfillment in your job is so much more when you can work with a child so actively that way, because you want active engagement, right?
Yeah.
Because if they're actively engaged, you'll know where they want to go, and you can see them live their best life.
Yeah.
And that's the thrill of being a therapist. You know, I don't think many of us thought about being a therapist to be in a session when you come out of it and you've got a headache and you're like, oh my gosh, that was hard work.
That was hard work.
That's not what we've got no longevity in that.
Yeah. Yeah. My colleague, Dr. Ashley Hines, makes fun of me because during Habitual intensive therapy camps, I do this thing where I go, aha. and, because I'm seeing a child master a new skill in a setting where they're happy, excited, engaged, focused.
Beautiful.
Of course, it happens all the time because it's Habitual and it's, intensive goal-directed training. Don't you want to live for the don't you want to? That's why I became a physio, and that's why I'm still doing it and still loving it today.
Yeah. And I love where this is headed in terms of, the practical strategies. I feel like for me, I really want to reassure clinicians and parents of going, yes, I know there is that hope for those first 1,000 days, but, enjoy the journey, enjoy your child, enjoy getting to know them, allow them to prioritize those great opportunities to get to know your family. And attachment theories is where it comes into, like, you want to build those beautiful relationships. And it's okay if we shift it a little bit, because there's actually a lot of great stuff out there, stuff that we know works, stuff we know that enriches lives, right? Like you're leading a study at the moment in Australia, which it's just a privilege to be a part of, and all I see is joy. Yes. And so this is the race running. I want to just quickly chat about that because I think it's worth talking about. It's really cool.
Amazing. Yeah. Thank you, Dana. It's a privilege to work with you as well. So Run for Health CP is a randomized control trial of a frame running intervention. So it used to be called race running. The official name for it now is frame running. Basically, intervention is not really the right word because it's really a training program. Yeah. It's actually about, it's not therapy. It's doing a sport. It's participating in a sport called frame running, which is specially designed and in fact developed by a para-athlete. So specifically designed for young people of all ages. I'm going to say young people, but people of all ages with balance and mobility difficulties, which of course is a lot of people with cerebral palsy. And it's 12 weeks of twice a week training, aerobic sprints, the skills, the whole kit and caboodle in a group, and it's meant to be fun. It's meant to be engaging. If any of you listening have done did a sport when you were growing up, you know, and you remember training, and sometimes training is hard, but actually sometimes training's fun because you're with your mates.
That's right.
You're working towards something.
Yeah.
You're working towards achieving something.
Yeah.
And, you know, sometimes you get to play games and you sweat a little bit. And that's what it is.
All great things. And I think what I've seen from it, so we've got the group going at the moment, and look, it's raining in Perth at the moment. So the team were still trying to find a solution. So I think they did it in the car park, so it was undercover because the kids didn't want to miss out. We've got children, GMFs is level 3, 4 and 5 doing this. They are school age. They are absolutely loving it. And again, it's that relationship, and they all want to continue to do it. So it's really positive.
Yeah, absolutely. Yeah. I think of a young girl on the Sunshine Coast who, in fact, it was pouring rain. It was a period sort of like a year and a half ago when at the Sunshine Coast there was just like seemingly endless rain. And she was like, no, I want to train. I want to train in the rain. And there's a beautiful photo of her just with the dark rain, storm clouds in the background, just like with this big grin on her face.
I love it. That just shows the possibilities.
Yeah.
And let's protect that relationship. And I think that's what it all comes down to, hey?
Yeah.
Yeah.
Couldn't agree more.
Sarah, I love this conversation. I'll talk to you more at dinner tonight, I'm sure. We've got heaps to talk about. But thank you for sharing and chatting about it, and just being really open to talking about this topic, which I think is so valuable.
Yeah. Thank you so much, Dana. Always a pleasure to talk to you.
Yeah, thank you. To all of our listeners, I hope you really enjoyed that as well. But stay tuned for more episodes. We'll talk to you all again really soon. Bye.